All right, guys. Well, looks like we probably still have a few people that will probably be filing in, but I'll go ahead and get started. My name's Mike Nystrom. I'm the criticalist over at Points East Vet Specialty Hospital in Wilson. Thank you guys, everyone, for attending. I hope that this will be a useful lecture for you guys. Sorry it's a little bit long. I am a little bit long-winded in that, but this is kind of a passion of mine, and I appreciate you guys' patience along the way. I do want to thank Vets Pets for putting this on. Even though I am a Points East employee, I am the bigger corporation is Vets Pets, and they're the ones that are putting this on, but just a pointer to Points East. A couple things for you guys. We'll be sending out CE certificates within about a week's time period after finishing up the lecture. I will also have them send out the presentation. You guys will get it in PDF form. Just that way you don't have to take notes on every single thing here. Just take the little points that you want to remind yourself later on. And then throughout the presentation, I'll stop 2 or 3 times just to do some questions, see what questions you guys have for that. If you have your mouse over top of wherever your Zoom aspect is, there's a Q&A. If you want to put questions in there, I'll try to answer them as many as I can during those little break time periods. And see what information I can give you guys on top of everything. And then lastly, throughout this presentation, I will ask, we'll have little surveys. I think it's about 15 or 16 or so surveys, just asking some questions related to the topics that we're doing. So one, for example, might be, where do you think this patient has a fluid deficit? We'll put out a little survey. You click A, B, C, or D. We'll give about 30 seconds. And then after that time period, we'll reveal what everyone chose, not as an individual, but as a percentage of everybody that participated. And then we'll go through answers like that. So I'll go ahead and get started. Again, thank you for attending. Excuse me. My name is Mike Nystrom. This is my passion is fluid therapy. I don't get into a whole lot of the ins and outs of the literature on this. I just try to keep it more basic and more functional for what you need to know from a clinical standpoint. A lot of this is targeted towards inpatient hospital care. That's predominantly what I do, but I also talk about some anesthesia aspects, as well as some things that you guys can do as outpatient care as well. So I hope that you guys enjoy it, and thank you again. And here we go. All right, so a little bit about me and my journey to joining the Vets Pets team. I'm actually a local to the town of Cary. Sometimes it makes my heart hurt to say that, but I did very much enjoy growing up there. I went to Appalachian State in Boone, North Carolina, where I'm a happy appy. Got to spend some games here with Joseph. I then went to the University of Tennessee for vet school. Graduated from there in 2013. Love this stadium, love going to football games there on the river here. It was lots of tailgating, boats lining up with each other, very, very fun. Awesome place if you've never been. And then spent a year up in the dreaded north in Massachusetts at Tufts Vet School up there for my rotating internship. Great time period. I really learned how to be a great ER doctor there. Frigid and cold, beautiful when it would snow, but too much snow throughout the year. So I ended up coming back down to the south, where I rejoined Tennessee and did an ECC internship, so emergency and critical care internship, and then a residency on top of that, which I finished up now coming up on 3 years ago. Since that time period, I was able to move back into the Raleigh-Durham area, worked at Triangle Vet Referral Hospital in Durham for a little bit, and have been with Vets Pets and the Points East team since about September of this past year. So really happy to be there, really enjoying it, and the team that we're building there has been fantastic. So what to expect during this presentation, we're going to talk about where fluid compartments are within the body, and how we're going to assess those for each of our patients, because I truly believe that we should do our best to kind of target our medicine that we do. And fluids is in itself a prescription that we're giving to our patients. And so I do find that to be very important, and one important topic to assess or discuss. And so we'll talk about how to assess that on our patient, and then how from there, we're going to use that information, choose a fluid type, and then how we're going to administer those fluids. And then at the end, there are a couple problems that we can work through together as a group. If there's a total of 3 different problems, I don't think we'll get to all 3 of them, but for those that are interested in staying for that last problem, it's a little bit more complicated one, a little bit more intricate. I'm happy to go through with those individuals. All right, so quick question about fluid compartments. So when you talk about fluid body water and weight, what percentage of a given patient, and let's talk about dogs and cats here, is made up of water, would you say? I'll give you guys about 30 seconds to answer this. All right, so let's see what everyone put. So about 11% of you put 45%, none put 50%. Majority of you put 60, and then a little bit under half put 75%. So good job. You guys are all very close. So ultimately, the total body water or total amount of water in the body accounts for about 60%. And this is pretty well conserved across many species. The difference is across the species is really an age kind of difference. So puppies and kittens are going to have a lot more percentage of body weight that is water, whereas adult and geriatric patients are going to have less body water. But think of it as roughly 60%. That's not necessarily a number that has a whole lot of influence, but just something for you guys to kind of know. And then if we take that total body water, we can then subdivide it into 2 big groupings. The larger of the 2 being the intracellular space, which accounts for about 3/4 of total body water. The smaller being the extracellular fluid space, which accounts for about 1/4 of that. I can go through the whole percentages. What is 75% of 60, but too many numbers just makes it more complicated. We're trying to make it as simple as possible here. And then the extracellular, and this is going to be the area that we manipulate the most in veterinary medicine, can then be subdivided into 2 categories again. And this is, again, about 75% and 25%, interstitial being the larger and intravascular being the smaller. So intravascular is very easy for us to imagine, everything within the vessels, really. Interstitial is that area where it's kind of a nebulous space, where what does interstitial really mean? And ultimately, it means that it's fluids that are in between cells. And that's always tough for me to grasp and say, gosh, how do I sit here and imagine that? And I really can't come up with anything useful for you guys. So unfortunately, I'm not helpful there. There is one last small category of space that accounts for less than 5% of this extracellular space, one that we're not going to talk about, but it includes things like cerebral spinal fluid and a few other categories that just don't really become clinically important or clinically relevant for most veterinarians. So we won't go into that. Big things, the intracellular space is a highly conserved space. And so for the most part, like I said, we will not be manipulating this. This is one that I will manipulate from time to time in our inpatients and mostly dealing with sodium manipulation in those patients. But for the most part, intracellular is pretty highly conserved. We're not really functioning or evaluating and manipulating that space too often. The interstitial space is probably the one that we assess all the time on your physical exam, hopefully. And that's essentially a hydration assessment on patients. And we'll go a little bit more into that. And then lastly, the intravascular space is going to be a volume assessment. So when we talk about hypovolemia, that's what we mean by volume. And we'll go through that as well. So next question is a deficit in the interstitial space typically life-threatening? So interstitial space, and is it typically, not always, but typically life-threatening? All right, let's see how you guys said. So 22% of you said yes, it is typically life-threatening, and 78% of you said no. So good. Most of you got that answer correct, which is good. But from a standpoint of can an interstitial deficit be life-threatening, the answer is absolutely. And it really depends on how severe it is. But for the most part, when we're talking about the interstitial space, it is not life-threatening. And we'll go over through that just a little bit here. So interstitial space, like I already said, is an assessment of the hydration of a patient. This, we have an ability to subjectively quantify deficits in. And then there is a somewhat objective measurement for that. And we'll go over what exactly that means and why that might become important in patients that you have in the hospital. This, again, this space is a deficit in this space is typically non-life threatening, meaning that a patient that has a deficit here or dehydrated is not going to die in a very immediate future. All right, so how do we quantify hydration? This is usually the point where I sit here during my residency and I point at a student and make them sweat a whole lot and say, well, tell me what's the minimum amount of hydration that you can assess. But unfortunately, I can't do that here to you guys. You guys are lucky that we're on Zoom. But so the minimum amount of hydration that you can assess on a patient is 5%. If you call me up, which I very much welcome you guys to call up and do consults with me, and you say, Dr. Nystrom, I've got a patient here that's been vomiting and it is 4% dehydrated. I'm going to go, tell me a little bit about how you came up with 4% dehydration. And if you tell me, well, he's got tacky mucous membranes and this and that, I'll be like, I think you got it a little bit wrong here. But if you tell me, I can't detect any dehydration, but he's been vomiting, I know he's got a deficit there, I just can't detect it, I'll be like, great job. I'm really proud of you. That's exactly what I want to hear you say. Sometimes I will use this as a chance to get a client to be more aggressive with treatment in patients than be more passive. So I have manipulated clients in a way to do that. Just that way we're doing best by my patients at least. So when we talk about the next category of dehydration, usually I'm talking about 5 to 7% dehydrated. And these are things that we're going to see with this category. We're going to start off with tacky or dry mucous membranes. And this can always be difficult, and especially in dogs or in cats that are drooling a whole lot. How do you assess that? And so that can be a little bit challenging. Some dogs or cats, you might be able to, mostly dogs, might be able to reflect back their prepuce or their vulva and see back there because they're unlikely to have as much discharge from there, hopefully. That might be an area where you can assess mucous membranes as well. Other things that we can see is an increased skin turgor. So that's that cat that you can do origami on their back. Typically, I assess that an increased skin turgor is probably going to be closer to 7% or so. And then we can see mentation changes. And what I mean by this is not an animal that's obtunded and not really responsive to you, at least this percent. These are going to be animals that owners report that, you know, they're just a little bit lethargic, not quite doing right, what we typically call ADR. Those are going to be those mentation changes that we're talking about. Just think about if you were ever dehydrated, that hangover that you have after drinking too much when you were back in college, or even now if you still party, you're going to be more lethargic, not as active as you would if you were adequately hydrated. All right, and then the next category or next spread is probably around 7 to 9%. We're going to see all of the above. So tacky mucous membranes, increased skin turgor, we can see mentation changes, and then we get things like a doughy abdomen. And this is always tough to explain to people what a doughy abdomen feels like. I never understood it. I think I remember the first time was end up with a parvo dog. You can feel it most of the time in kittens and puppies is a little bit easier. But if you think about that increased skin turgor, and that's because of decreased fluid in the interstitial space. Well, the lining of the abdomen has a small amount of fluid that kind of keeps everything lubricated, moving in and out amongst itself. But if you get dehydrated, you get everything starting to stick to itself a little bit more. So whenever you palpate that belly, it just doesn't fall back into place like it normally would. And that's considered a doughy abdomen. So a little bit tough. Like I said, again, in young juvenile patients or pediatric patients, you'll be more common to find it. And then as probably you get closer to 8% or so, you can start to see sunken eyes. And remember that there's a fat pad in the back of the eye or right behind the eye. And that fat pad has a lot of moisture in it. Whenever we lose the moisture in that, our eyes start to kind of sink into the back of our head. Now, if you have a really skinny patient or a cachectic patient or one that doesn't have as much temporal muscle mass, they might already have sunken eyes. So you just have to take it with a grain of salt. Also with regards to skin turgor, think about the old crusty cat that has chronic kidney disease, always gonna have a prolonged skin turgor. No matter what you do, always will have that skin turgor. So you just have to make sure that you're assessing your patient based on concurrent diseases and everything else to make sure that you are in agreement with your exam findings. So the next category is 9 to 12%. this is not really where you want a patient to be. And this is where we're starting to get into concerns for their hemodynamic stability or death is pending. So we'll have all the above. So the doughy abdomen, sunken eyes, skin turgor, changes, and then we can potentially even have coma. I have seen a few of these patients. These are not good. Not good at all. We don't want to see them at this state ultimately. And then anything greater than 12% is life-threatening. So you can see coma and death in these patients. And this is very scary, not good situations. Most of the time, whenever you're getting probably above the 9% mark, you're probably having a little bit of interconnection between the interstitial space and the intravascular space. And that's also going to lead to concurrent concerns for impending doom for that patient. All right, so this is rough idea of how to quantify hydration. Remember this is always very important. So whenever you're assessing patients, these are things that you should be looking for, especially in patients with a history of vomiting or not eating enough. Whenever I assess mucous membranes on patients, I do 3 things. 1, assess their color. 2, their texture, and then 3, their refill time. And I always encourage you guys to try to include all 3 of those in your record as much as possible. You can say pink, less than 2, and moist, pink and tacky, less than 2, that kind of situation. All right, let's see. All right, so curiosity question. What is the most significant dehydration that you have ever seen in a patient? Sorry for the little typo here, that should say most significant dehydration. Let's see what you guys think based off of how we described that previous slide. For those of you that have already answered this, and those that kind of came in late, I'm going to end up sending out your CE certificates along with a PDF of the presentation within about a week after the presentation. So if you just want to take the main PowerPoint notes that you think are big points to remember, you'll get a copy of the slides later on. All right. Ooh, wow, about half of you seem 10%. Oh gosh, almost a quarter of you, 12% or greater. That's good and terrible at the same time. So that's good. I would have expected most of you to see probably 6 to 8% or so. So you guys have seen quite a bit, and I guess that certainly makes sense. I always, whenever I see that 10%, I always start to my adrenals start to squeeze a little bit, and I certainly don't enjoy that very much for the patients. All right. So I talked about there's a possibility of an objective assessment of the hydration space. And this is it is an objective assessment, but it's also tough because many things can affect this assessment. So in particular, we're talking about, with regards to a patient, if this in the middle is our hydration status, so going from euhydration down at the bottom, all the way up to potentially 10% dehydrated at the top of the pyramid here, we look at our PCV and total solids. As we get more and more dehydrated, our PCV and total solids are going to be increasing. And this assumes no loss due to hemorrhage, no loss due to diarrhea of proteins or any other protein loss. So if we have just a patient that, let's say, is PUPD, got locked in a closet for the weekend and didn't have access to water, this would be the perfect assessment of that patient. Remember, this is when most of us, I hope, at least I remember learning a whole lot about it, was this hemoconcentration aspect of veterinary medicine, or dehydrated patients, and this is exactly what that's talking about. Hemoconcentration is an assessment of the interstitial space. One other assessment, and this is again now we've got our pyramid in reverse. So euhydrated is at the very top here, just outside the 5% zone, and then very dehydrated is down here at the 10%. This is one other assessment. So if we have a patient come in that has, let's say, a 7% dehydration, and we have their weight, and I typically do things in kilograms, so forgive me if you do them in pounds. But we can sit here and say, based off of their weight in kilograms, I can calculate, and I know that they're 7% dehydrated, I can calculate how much of a deficit of fluid they have, and they should regain that weight when they finally become euhydrated. So for this, we're looking at body weight, and as we become more adequately hydrated, our weight is going to be increasing. And again, this is very simple. If we have 5% of our blood or of our water volume lost in our body, our weight's going to be down. As we rehydrate, we're going to retain water, and our weight's going to increase. So that's an important thing that you can use to sit here and say, my patient was 7% dehydrated, yesterday when I assessed it, but it's had some diarrhea. Am I really where I think I need to be? And then you can sit here and weigh them and say, all right, from a weight standpoint or an objective measurement, I haven't gotten quite where I want to be. And so this is something that I use very often for patients that have chronic or not necessarily chronic, but very marked diarrhea. Parvovirus patients are the perfect example of this. And so I use weights to kind of target my therapy as best as possible. All right, so in summary, a deficit in the interstitial space is called dehydration, and it is typically not life-threatening, typically not life-threatening. As we talked about, it absolutely can be whenever it gets severe enough, and certainly our adrenal squeeze during that time period. All right, so question about intravascular fluid deficit. Is a deficit in this space typically life-threatening? So are these patients with a deficit, are we concerned about them dying imminently on us when they come in? All right, let's see. Oh, yes, I love it. Good job, guys. 100% yes. I'm feeling pretty good here. Good job, guys. So yes, a deficit in the intravascular space is absolutely life-threatening. And we'll go over how to assess the intravascular space because we have a number of different things that we can use for that. So like I talked about earlier, when we talked about the different fluid categories or fluid spaces, intravascular fluid space is a volume assessment space or volume status in a patient. Unfortunately, unlike the interstitial space, we are unable to assign a given percentage or given volume that a patient is hypovolemic. So we can't say this Labrador is hypovolemic by 325 milliliters and target giving that back to them. All we can do is just sit here and say, I've got evidence of hypovolemia, or I've got evidence of intravascular deficit, and I need to target therapy. Remember that the intravascular or the vascular tissue itself has muscles associated with it. So it's going to expand and contract as it needs to try to be able to stabilize a patient. If you think about an anaphylactic reaction patient, their vessels are wide open and they probably are euvolemic, but they just have wide open vessels. So that volume isn't enough for them anymore. And so we got to get them to contract down with epinephrine. And also we will often volume load them a little bit as well. All right, and again, like we talked about and like you guys all got right, which I'm so awesome, so proud of, this is typically a life-threatening condition when we have a deficit in space. All right, so what are we going to use to assess this? And there are a number of assessments here. The one thing I want to point out to you, I am a cat person. Anything I say about cats in here, please take with a grain of salt. From a medical perspective, I hate cats. Hate them, hate them, hate them. They don't follow the rules. They're more like a horse, and we're not doing small animal because we want to work on a horse. With that being said, we'll talk about some of the little differences or intricacies between dogs and cats. But for the most part, most of these assessments go across both species. So when we talk about mucous membranes, we're going to talk about color here. So we talked about texture already. Now we're going to talk about color as the second part. So animals with a intravascular fluid deficit or hypovolemia, they're going to be pale or white. And this is where cats, their first strike is against them here. Because many cats, most of the cats that I assess are a pale pink color with a gingival line or gingivitis line, no doubt. And so you just have to take it with a grain of salt, assess the patient as a whole, go on other indicators as well. But for dogs, definitely you see pale or white, start being worried about intravascular deficit. You can also be worried about anemia, of course. Capillary refill time, the third and final assessment of mucous membranes. If we have a prolonged or greater than 2-second refill time, or we're unable to assess that, start thinking about an intravascular assessment or an intravascular deficit issue. And this happens because we get vasoconstriction to those capillary beds, because let's be honest, mucous membranes are not important to salvage, not like a kidney, not like a heart, not like a brain. And so the body will shunt blood flow from areas like the mucous membranes, the paws, and other areas to the more important organs. The viscera also included in this, but viscera even gets shunted to some degree. And so that's why we get both the pale color, because we don't have a lot of blood flow to it, and the prolonged refill time, because we've got vasoconstriction to that. Distal extremities, just like I said, not very important to save whenever an animal's in shock. So in animals, especially now these days, now that we're starting to get warmer outside, they come in with cold extremities, start thinking about concerns for hypovolemia and shock in those patients. Blood pressure, if you guys have a way to assess this, hopefully most of you do, whether it's oscillometric, and that's the device that you hook up to and it goes and pumps up, and then slowly releases and gives you a systolic, mean, and diastolic pressure. Or if you're using something like a Doppler flow or ultrasonic flow meter, most people just call it a Doppler, and you're getting systolic if you're getting low values there. So we're talking about systolics below 90, means below 60 to 70 or so. So if you're unable to obtain them or you're getting them below those values, and that would fit with a patient that could have an intravascular deficit. In cats, again, strike number 2 for cats. Dogs do not follow this very often, but cats, typically if you have a hypothermic cat, that is one of 3 things for me that is almost pathognomonic in cats for a cat in shock. We'll go through the other 2 here shortly. Abnormal mentation, this is where we kind of have a cross between dehydration and hypovolemia, because we're going to see these guys be dull. We're going to see them be stuporous or tunded, coming in on death's doorstep. That's what you kind of expect to see. But it's tough to differentiate this between dehydration if we're not assessing anything else. And so that's why it's important to always assess all these aspects of a patient. Strike number, is this 2 or 3 for cats? I think 3 now. For dogs, typically will become tachycardic, and this is part of the compensatory shock mechanism in dogs that then becomes decompensatory whenever they become hypotensive on top of it. But dogs will become tachycardic, and so something that I look at in dogs is a comparison between the tachycardia or the heart rate of a dog and their blood pressure, systolic blood pressure. And you can compare them. So if you have a really high heart rate up here with a non-painful dog, and their blood pressure is down here close to about systolic, let's say 100, but their heart rate's 200, I would say that's a patient that's in shock, because that deficit, that difference is inappropriate. Ideally, we want them to be close to about a 1 to 1.2, 1.4 ratio when we talk about blood pressure. Sorry, when we talk about heart rate compared to blood pressure, that's something called the shock index. Cats, oh, cats. I love me some cats. But cats, for some reason, become bradycardic whenever they're in shock. And so this is a very interesting phenomenon, one that I have no idea why it really occurs. I probably should, but that part of me and education and the academic aspect has gone. Sorry, guys, if you wanted to know all that. But bradycardia is something that you certainly see in cats. And so that's the second part of the triad in cats. But the third strike against cats is them just being silly patients for a hospital. If you guys have the ability to assess a lactate, whether you do it on your in-house analyzer or you have a small lactometer, they're about the size of a glucometer. These patients are going to have an elevated lactate because they're going to not be perfusing or oxygenating tissues well enough, so they're going to start going into anaerobic metabolism, leading to elevations in lactic acid. And that's what we're measuring there. There are other things that affect that. So there's type A lactate and type B. Type B is non-life-threatening lactate elevations that you can see with stuff like Cushing's disease. I'll leave it at that, and that'll be the only thing that I say about that. But type A is what we're really concerned about here. And then the cat, again, the cat. Ugh. Cats can develop a tachypnea because their lungs are the shock organ. Unlike dogs, with their typical shock organ is the GI tract. So cats you'll see become tachypnic. And then you've got this cat that's tachypnic, maybe bradycardic, hypothermic, and you're going, shoot, is this cat an asthmatic cat? Is this cat a heart failure cat? Or is this cat in shock? And that's where it's really like, this is where, well, they're cats. What I would say is that if you have a bradycardia in a cat, it's unlikely that it's due to congestive heart failure, though my mentor and the cardiologist I worked with would argue otherwise. I feel like from a clinical standpoint, I have seen very, very, very few heart failure cats that are bradycardic. Hypothermia does follow with a heart failure in a cat. In a cat that is having an asthmatic attack, they will not be bradycardic, and they typically will not be hypothermic. So that is less likely to occur in those conditions. So I would say tachypnea in a cat with bradycardia and hypothermia are the fantastic triad of shock, blood pressure, not tachypnea, but the triad of shock in cats. So low temperature, low heart rate, low blood pressure. So patients that present to me through the ER, I will have nurses, if I have temperature and heart rate are really easy to get. Blood pressure sometimes a little bit more challenging. If I have a hypothermic bradycardic cat that comes into the ER, I'll have my nursing team try to get a blood pressure on them. And I'll say, do it for about 2 minutes. If you haven't had success, kind of move on. And then we're going to treat this cat aggressively, especially if I'm convinced that it's more related to hemodynamic instability as opposed to cardiogenic in nature or related to something else. And so this is the triad of shock in cats. Important things about cats also, until you get their temperature at least to about 98 degrees Fahrenheit, you can bolus the snot out of them all day long. So you can give them bolus after bolus after bolus of fluids, and it will not do anything. And then you get them warmed up, and all of a sudden, all that fluid that you gave them, these 19 boluses, please don't ever do that. Call me after 2 or 3. But all these boluses then become functional volume, and then that cat is now fluid overloaded, and you push it into heart failure, which is not really heart failure unless they have heart disease, but and then they become tachypnic because their heart cannot tolerate all that fluid. So do be careful. Give cats a bolus, ideally of warm fluids, and then aggressively warm them as much as possible before you start here bolusing them multiple times, would be my recommendation. All right, everybody love cats as much as I do? Good. All right, so back to our little chart. This is similar to the interstitial space. So we have hypovolemia, which is the same thing as a deficit of the intravascular space, which is the same thing as a condition that is typically life-threatening. So you guys all got it right, so I don't need to go over this anymore. Great job. I hope that I explained that well enough. And these are the important things to remember whenever you're assessing a patient, how we're going to assess the interstitial space and the intravascular space. Because it's going to be important because we're going to treat each one of them differently. All right, let's see what's next. All right, and then there's these patients that come in that typically have more than one deficit going on. This is probably I'd probably say about 20% of patients coming in through our ER have a deficit in both of these spaces. And so we've got to make sure that we're weighing which one is more important. And for this, I hope that you guys can join me in going, the life-threatening one is more important. So we're going to talk about hypovolemia being more important. That's the patient we don't walk away from. And then once we get a euvolemic patient, then we can start working on rehydrating them. All right, so here's where I'm going to take a moment. If you have any questions, please type them into the Q&A here, and I'll hopefully be able to answer some of them. But interesting fact, Triceratops have tons of teeth, and they are really dense. They have up to 800 teeth. Isn't that fascinating? I think so. I mean, how much would you love if you were I don't know if it would be an equine farm animal vet and you had a Triceratops, so you had to go out and wear down those teeth if they had uneven edges, what are the hooks, whips, valleys, everything that they do with teeth. I'm sorry if there's any large animal vets out there. I've failed miserably. I'm too far outside of it. See if we have any questions. All right, no questions. I'll give you one more second. Anybody? Oh, here we go. How do you warm the fluids before giving them to patients? That is a fantastic question. So at the hospital at Points East, we have a fluid warmer that we use for warming saline bottles for surgery. And we have a couple bags of fluid in there. That is most ideal because we can put them in there. They're ready to go whenever we have a patient. But do remember that if we're hanging a bag of fluids way up here, and then we've got this long line going to the patient, even if we're bolusing fluids, it's unlikely that through that line, they're going to be still warm going into the patient. The better thing to do, and this is mostly important with cats, is to draw out volume of fluid out of that warm bag of saline and give directly into a catheter. That way you know that they're warm. So that's the best way to do it. If you don't have an opportunity to do that, you just have to be very careful. I would not recommend that you heat them up in a microwave, because how many people have drank coffee and had hot and cold spots? Not good. You usually want to mix it up a little bit first. And I feel like it often wastes some degree of time. There are fluid warmers that can go along the line that you can place right before they go to the patient. They do an all right job, but they're more probably for lower fluid rates. Bolusing fluids on an IV line that goes through there, they're probably not going to warm them sufficiently. Any other questions out there? All right, if you have any questions, feel free to type them in. I'll try to answer them the next time we have a little sideshow here about Triceratops or something else. All right, so now we're going to get into talking about fluid types. And this is where we can get into the nitty gritty. This is a little bit more information here. And then the next time is how we use those fluid types. There are two categories of fluids. We talk about colloids and we talk about crystalloids. Most of the time, in most practices, you're probably going to be dealing with just crystalloids. The ER settings, specialty hospitals are probably going to be doing a little bit more colloidal therapy. But we'll go through what colloids are or what we have available in veterinary medicine. So colloids, remember, these are things that are going to pull fluid into the intravascular space because they're going to be more likely to hang out in that space and pull fluid from the interstitial space, which is very important, into the intravascular space. So they're more likely to hold fluid into that space, contribute to colloidal oncotic pressure, which is fancy doctor ways of just saying that it's going to contribute more to blood pressure aspects of things. But the one caveat being, most of these colloids pull from the interstitial space. So if you have a patient that's 7% dehydrated and you give them a bolus of, let's say, vet starch, you're pulling from that interstitial space that's already pretty well depleted, trying to pull fluid into there. So you might not get as much bang for your buck as if you had a patient that is hypovolemic, but euhydrated. Hope that makes sense for everybody. All right, so what are we going to see on, or what type of fluids do we have available? The biggest one and probably the one that's most common in many places is the hydroxyethyl starches. These are our synthetic colloids. We'll go through a little bit of those and what products we have available. Fresh frozen plasma and frozen plasma, these are definitely considered a colloidal product. I have never given plasma for patients that are hypotensive. You have to give them large volumes of plasma, and it's often bolusing them, and the volume is not sufficient, or sorry, the albumin that you get from it is not sufficient to raise up blood pressure sufficiently. So I do not recommend giving this for that utility. You can give it for coagulopathies. So a rodenticide dog comes in, or an anticoagulant rodenticide dog comes in, a hypoalbuminemic patient, maybe you just have to give a decent amount of plasma to do that, or clotting factor deficiency. So things like a hemophiliac would be a reasonable thing to target for using that. Albumin, that is something that is not used commonly. There is human serum albumin, or HSA. And that's what many of the veterinary studies look at out there. There's also canine albumin that's now become commercially available. I think it's through Animal Blood Resources. Is the ones that have canine albumin. I haven't found that it's as big of a bang for your buck as human albumin, but remember that it's more natural to a dog patient. Human albumin is a foreign protein. They are more likely to have anaphylactic, or more likely actually to have delayed sensitivity reactions to those. And you're going to use these for hypoalbuminemic patients. Immunoglobulin, or human IVIG, again, a human product. These are typically patients that we're going to give them to are often pretty sick. But this IVIG can bind. So it is the IgG function, or IgG, I believe. Now I'm having second thoughts on this one. Aspect of antibodies. And what it's going to do in the body is it's going to bind to certain things in the body. We talk about these Fc receptors, just the fancy specialty terms that we use. It doesn't really matter, but it will combine to both white blood cells of different types, as well as antibodies in the circulation, and hopefully take care of any immune-mediated diseases. Again, this is only going to do what's in circulation. So we can use this for things like immune-mediated thrombocytopenia, hemolytic anemia. I've seen it used for some dermatologic disease, which is absolutely fascinating to me. Dermatologies are also absolutely terrifying to me. So please, if you want to send them, I will do the best I can. Just don't hold me to it. But this can certainly be used for that. And this is something that's not very readily available. Many times I'll have to go to a human hospital to be able to gain or get some. Oxyglobin is something that is unfortunately not available. I have never used it, never seen it. but I've heard great things about this. So this is fractionated bovine, so cow hemoglobin, and it's just the hemoglobin molecule. So it's very small and can carry oxygen. And this has a huge benefit in patients that are anemic, because now we don't have to worry about red blood cells to carry oxygen. We can have this hemoglobin molecule. And patients that are hypovolemic, because it's fantastic at creating volume expansion by pulling fluid into the intravascular space. This also has the benefit that areas where red blood cells are having trouble getting through because of, let's say, DIC type situations where you just have clogged up blood vessels, hemoglobin product might be useful for getting oxygen to those more narrow cavities or distal surfaces. Sorry, I got something stuck underneath my table here. Packed red blood cells is probably something that you guys might use more commonly. It is something that is technically a colloid, but we do not use it for colloidal effects. But just something important to remember for those animals that have heart disease, be very careful about how much and how fast you give it. And then lastly, whole blood makes perfect sense because it's got albumin in it. We're going to be giving this for animals with hemorrhage as the primary cause, or if you have a blood donor and an animal needs red cells, but you just have whole blood is all you've got available to you. So that's a utility there too. All right, so let's ask about colloids. So how many of you have access to at least one of these colloids that we just got done listing? All right, so it looks like about half of you guys have access to one of these colloids. Fantastic. I will be honest that from a colloidal perspective, I don't use them very often. So if I didn't have access to them, I probably wouldn't be too upset about it. I do have access to many of them, and I'm very fortunate for that. But I'm not surprised that only 50% of you have access to it. Not a big deal, not the end of the world. And we'll go over that a little bit. One more question here. So how many of you, the 50% that do have access to a colloid, have hydroxyethyl starch? So this is things like vet starch, Voluven, hetastarch, pentastarch, tetrastarch. There's buckets of different starches. But how many of you have access to these or have them available in your hospital? All right, so about 2/3 of you have access to one of these products. So this is predominantly what I probably would end up using many times. There are risks associated with that or with the product, so that's important to always take into consideration and remember. We'll go through a couple of those risks here in just a little bit, and kind of so that way you guys know, and then you can try to make an educated decision on in the future. And I will not go through all of them or the ins and outs of it either, but just to put some ideas or some thoughts in your head. All right, so the hydroxyethyl starches, just like what we were talking about, these are the same thing as synthetic colloids because we manufacture them. There have been 5 total studies looking at the potential risks or side effects of these hydroxyethyl starches. All of them, unfortunately, are retrospective in nature, how many things go in veterinary medicine. But the one thing that they're always looking at is, if you look here, acute kidney injury, this talks about plasma creatinine. I forget what that one says. Again, serum creatinine here, and then I think this is the end of creatinine here on this one as well. So they're all looking at an acute kidney injury related to these medications. In human medicine now, about, let's see, it was 13, 14 time period maybe. There was big studies that were put out in human medicine, especially in the European Union, that there were a lot of humans that were developing an acute kidney injury requiring renal replacement therapy and potentially an increased mortality related to use of these products. Now, we're not dealing with humans for ourselves. And so does this correlate to our population or not? It's very tough to tell. There's only been one study, this one here, that has sat here and said that there might be a correlation between using these products and development of an acute kidney injury. And I forget how they define it in this study. Typically these days, people are defining as a creatinine increase of greater than 0.3 points over a 24-hour time period, is what they typically are recommending. They also look at urine output values, but we're not going to get into that right now. The one thing that I want to point out, let me go back. Oh no, here we go. Make this a little bit smaller. For this product, or for this paper, they looked at a 10% solution of hydroxyethyl starch. That means they have it probably diluted in lactated ringers or in saline is what most of these come in. It's a 10% solution. If you look at all these other products in these other studies, they actually used a 6 or 7% solution, even though it doesn't say in their title. And then other things that it gives is the molecular weight of the product. So 250 compared to 130 for the other ones. A molar, let's see, a molar substitution, a 0.5 of 0.4. And the last thing that none of the other studies give is a C2 to C6 distribution of these hydroxyethyl molecules on them. All fancy ways of saying these might be things that influence it. Higher molecular weight means that it's not broken down as quickly. A higher molar substitution means that, again, they are unlikely to be broken down as quickly in the body. And then the C2 to C6 is a similar, but not as well proven or discussed opportunity. So I think this study here in the middle is actually one that it might stand alone on itself for the remainder of veterinary medicine, because it's probably a markedly different product than what most of us are using. The products that we currently use now are more these 130, 6 or 7% products. I believe the Betastarch and Voluben are a 6%, 130.4, and then I forget the C2 to C6 substitutions on that. So I don't think it's going to be a thing in veterinary medicine. I certainly don't think it's going to be a thing in cats because they're their own unique thing. Though in human medicine, they do talk about septic patients being more likely to develop these AKIs and require renal replacement therapy. So maybe if you have a septic patient, think twice before grabbing it. What I will tell you, most of my septic patients, I have to grab this on. What am I going to do? You know, I've got to maintain their blood pressure. This might be the only thing that I have available to do that. So that's going to be it. There are some other differences or some other risks associated with hydroxyethyl starches. Talk about platelet closure time, effects on the coagulation cascade, essentially all those fancy ways of saying that it might affect how much a patient is bleeding. But from a clinical standpoint, I haven't seen that it has much effect, but just a thought out there. And there are a few other things as well that we're not going to get into. All right, so our crystalloids, the bread and butter of this presentation, the most important aspects of this presentation. I'm going to have to step it up a little bit quicker here. We have 3 different crystalloids that we can use. We have hypertonic, isotonic, and hypotonic. And these are not crystalloids. These are groupings of crystalloids. And this tonicity is what we're referring to relative to the tonicity of plasma, which is about 300 milliosmoles per liter. In cats, it's a little bit higher. In dogs, it's a little bit lower. 300 is all you really need to know. And so this is where we're going with the tonicity relative to plasma in patients. All right, so next question, or next polling question is, what is the preferred fluid type of choice for most instances in veterinary medicine? So is it hypertonic fluid, isotonic crystalloid, or hypotonic crystalloid? What do you guys think? And I do see that we've got 2 more questions. I'll get it at the next little break and answer those questions. It looks like one was a statement, one was a question, and I'll comment on both of those later on. All right, so fantastic. 90% of you said isotonic. That's fantastic. That is exactly right. So isotonic crystalloids is going to be the treatment or the fluid of choice for most instances in veterinary medicine. And we'll go through those a little bit here and here shortly. All right, so crystalloid assessment. So as we go through this presentation, you guys will see this chart, and I'll put it up for each type of crystalloid that we're looking at. We're going to assess what the fluid type is. So this is going to be lactated ringers versus normal salt R versus hypertonic saline. Whether or not it's a balanced electrolyte solution, what that means is, does it have stuff other than just sodium and water in it? If there's a buffer component, and that's important to know for whether or not it's just kind of, and it gives an opportunity for the body to sit here and take this buffer and help with stabilizing or offsetting hydrogen ions within the body, and then what the sodium concentration is. And the sodium concentration is probably the most important thing for me whenever I'm looking at my fluid type and what I choose. All right, so first up, hypertonic fluids or hypertonic crystalloids. We've got one option in veterinary medicine typically, and that's hypertonic saline. I will sit here and say that in human medicine, it seems like they've got a lot of varieties of hypertonic saline. I've only ever seen one, and that is this one here, 7.2% hypertonic saline. The fantastic thing about this is that it's cheap, dirt cheap, and you give a small volume to get a big result in patients. And so hypertonic saline will be anything greater than 9.9% saline, which is considered physiologic saline. And we're going to use these for resuscitation. So animals with a hemodynamic collapse, hypovolemia. We can also use it for cerebral edema hemorrhage, so head trauma patients. And then lastly, we can use it for hyponatremic patients, which I would say be very careful. Manipulating the intracellular space with regards to that can be very difficult, and you can run into negative side effects by increasing sodium too quickly. The brain cannot increase as quickly, and then you can lead to either crenation of your brain, or what we actually call pontine demyelination, I believe is the proper term for it. Or if we're going from elevated sodium to lowering the sodium, we can lead to cerebral edema if we drop that sodium value too quickly. So just be careful with that. That is something that I love to do. So if you ever need help, give a call. So when we look at hypertonic saline, 7.2% saline or NaCl has no electrolytes other than sodium and chloride in it. And then it's just water. It has no buffer in it. So it is a little bit of an acidic solution. And then the sodium concentration is 1,232 milliequivalents per liter. That is, whoa, like a lot. In a normal animal, think about what the sodium values are you're getting on your chemistries, somewhere around about 145, 155 or so. So 1,232, wow, sodium. So expect if you give a bolus of this, expect that animal's sodium to be sky high, 165, 170 after a bolus, and it'll slowly trend down over probably the next 6 to 24 hours or so. All right, our isotonic crystalloids, bread and butter of veterinary medicine fluid therapy. This is our fluid type of choice. This is what we're going to reach for 90% of the time. For me, 90% of the time, probably even more. One big note is that these are a replacement fluid. And what that means is that from a physiologic standpoint, the amount of electrolytes that are in these fluids, the sodium being the main one, chloride being a secondary, but even our potassium, magnesium, calcium that are in some of these fluids, depending on what type of isotonic you're using, they're a replacement fluid, meaning they are giving elevated or excess levels of some things like sodium and lower levels of other things like potassium than what an animal needs on a daily intake. There are maintenance fluids, which we will talk about. Those are typically the hypotonic solutions, but you often have to add things to those to get them to be a true maintenance fluid. So that's what a replacement fluid means, really. Don't worry too much about it. Just know that isotonic crystalloids, if you have one choice, only ever go for isotonic crystalloids. All right, so we got 4 available to us. 0.9% saline or physiologic saline, Normasol R, Plasmolide A, and lactated Ringer solution or LRS. There is a Normasol L, I believe. No, now I forget. Let's see, Normasol M for maintenance, Normasol R for replacement is what those stand for. And there's a Plasmolide something. Those are more maintenance type fluids. I have not seen them in decades. So probably unlikely to see those out there. If you had to choose one of these fluids, it'd be big boy in blue down here. Lactated Ringers, to me, is the most balanced fluid that we have. Saline is one that I probably use the least frequently. If I had all 3 available to me, saline would be the least one used for me. So just to let you guys know. All right. So when we look at these, again, back to our chart, we'll look at each individual one. 0.9% saline is not a balanced solution. It has no buffer. And the sodium concentration is 154. So that sounds close to normal on a patient, right? But do think that in a given day, they probably don't take in this much sodium. The body is really good at conserving sodium because that's a big factor in maintaining the intracellular space. So 154 milliequivalents per liter is a little bit more than what the body needs. If you put a cat on 0.9% saline, guarantee you their sodium will start creeping up very quickly within about 12 to 24 hours. You put a dog on it, they're a little bit more tolerant and can handle sodium. If you put a chronic kidney disease animal on it, holy smokes, they go through the roof. They just don't tolerate sodium levels as well, or sodium loads. Plasma-Lyte A is the next guy. It is a balanced electrolyte solution, so it does have other things, other fancy things like magnesium. Don't hold me to the magnesium, but these are just examples of what they have. Potentially calcium and potassium in them. It has a buffer component that's acetate, and its sodium concentration is 140. So a little bit better for a patient, a little bit more tolerant of most patients. Normasol R is, for all intents and purposes, practically the exact same solution. So if you only, there's no reason to carry both, is what I'm saying, really. Choose one, don't waste your time on the other. The buffer component's an important thing when we talk really about typically one condition, and that's liver failure or liver insufficiency in patients. And that's because lactated ringers here, like the name suggests, has lactate as a buffer. This is not the same type of lactate that we measure with a lactometer. There have been studies shown that in minuscule, small amounts, large volumes of LRS can be given and only change peripheral lactate on a lactate meter, very small amounts. So don't worry about it. The body takes this lactate, the liver takes this lactate, and then converts it to the buffer component. But if you have a patient that has liver insufficiency, this might be a little bit more of a challenge to them. What I will say is that we don't see liver insufficiency, true liver insufficiency, enough to justify all three types or all four types of these fluids. And if you only get one, get lactated ringers. And the real reason for that is the sodium value. So 130 milliequivalents per liter. I am more likely or less likely to have a patient develop hypernatremia because of that lower sodium. So all of my cats that I take care of in the hospital, I preferentially put them on LRS. If I had other choices, I would always put them on LRS. So just a thought there for you guys. But so if you have one fluid type, go for LRS. If you want a second, go for either Normasol R or Plasma-Lyte A. Do not get both. It's a waste of time. It's a waste of money. Hopefully that helps you guys. All right, and then lastly, our poor hypotonic crystalloids. So these are going to be things like 0.5%, 0.45% NaCl, and it might have dextrose in it. Some people call it half and half is what I always grew up calling it. And by grew up, I mean like 6 years ago. D5W or dextrose 5% in water. So both of these solutions are majority water. So 5% dextrose in water, we add that 5% of dextrose in there to make it a isotonic solution going in. So essentially what that does is when you give it into the IV or into a vessel, it keeps that vessel from becoming all phlebitis-like. Because it really gets upset if you put in something that's hypertonic or something that's isotonic for long periods of time. And same thing with the 0.45% saline, adding the 2.5% makes it an isotonic solution. The body effectively in non-diabetic animals will secrete insulin, and then that dextrose will disappear. So effectively it is an hypotonic solution. All right, and then lastly, sterile water, which no one uses. Bad idea. Just ignore that I put it in there, but it's an opportunity. Use dextrose 5% in water, D5. And you can, if you have a bag of sterile water, you can add dextrose to it and calculate 5% to be able to give it at that. Again, these are maintenance fluids because these are giving sodium levels, at least the 0.45% saline, is giving sodium levels that are more appropriate for what an animal needs on a daily basis. All right, our chart again, neither one of them are balanced. Neither one of them have a buffer. The 0.45% saline has 77 milliequivalents. D5W clearly has none because it's just water. All right, and that is our crystalloids. Oh, sterile water is on there too. Forget about it, just ignore it. All right, so interesting fact, jellyfish and lobsters are immortal. Who knew that? Who wants to be a jellyfish now and just float around an ocean and not have a job except for just catching fish? It doesn't sound very exciting to me. But let me answer a couple questions here. So someone said that regarding fluid warming that you make an IV fluid warmer using a light bulb and a cooler. That's interesting. I guess it makes sense for if you're warming up a cooler similar to like a reptile cage. So that makes perfect sense. I like that. Let's see, someone else said, can bovine albumin, here goes a large animal person. Oh man, I actually know this person too. Be useful. It's pretty readily available. I have never seen someone use bovine albumin or heard of it being used. In my residency, we had both human albumin and canine albumin available. So I had better products or products that have been studied. And so I don't really know the answer to that question. I guess in theory, if you're backed up against the wall, as long as you talk with an owner and be like, look, this is not something that's registered in veterinary medicine, not something that I know about, or if it's effective because we don't have the studies, maybe you could consider using it. Sure. Let's see. Someone said, I use Hetastarch for my hypoproteinemia patients that have a protein losing enteropathy. Is this appropriate? I only use one bag until I can start managing the cause of the PLE. That is a fantastic question. I've had this similar question about whether or not we give albumin products to these protein losing enteropathy dogs as well. And I don't have a great answer for that. It's very challenging to know if these hydroxyethyl starch products are going to have an effect in the intravascular space like you have a desire for, or if they're going to have a negative effect. So meaning, do they extravasate eventually and then cause more havoc than if we didn't give it? And I do not have a great answer for this. I have used it in patients that I'm having trouble with blood pressure that have protein losing disease. I will say that protein losing nephropathy, so protein losing kidney disease, maybe use it more selectively and be very careful. And the only reason for that is the association with AKI may be more prone in kidney disease patients. I don't really know. And so if that's what you have and you found success with it, continue to use it. Just try to use it at lesser volumes, right, or just the volumes that you need and nothing more would be my recommendation. And then last question, in what situations would you need a hypotonic solution? Fantastic question. So hypotonic solutions are mostly going to be used when you are either trying to do your best medicine and only give an animal what they need on a maintenance base. So NC State, I believe, here locally, does use the isotonic crystalloids for rehydration period and for giving animals back their deficits. But I've heard, and this is, it's been years, but I've heard that they use a hypotonic solution for a maintenance rate. So they'll put them on two different solutions. They'll rehydrate a patient with their isotonic, and then they'll put them on a maintenance rate with their hypotonic solution. Maybe that's more physiologic in patients. It's tough to really know, but I think it's a possibility that it could be. Otherwise, I use them whenever I'm dealing with patients that have a pretty significant hypernatremia. So back to our chronic kidney disease animals that are less tolerant of fluid loads, I might put them on a maintenance rate of fluid with a hypotonic solution and then a either rehydration or a diuresis rate of fluids with a isotonic crystalloid. That may be more effective and may be better for a patient. Let's see, did that answer all the questions? Got one last one here. How would you classify the hydration changes associated with an HGE dog? Oh, great question. Always tough. And this is where you use your PCV solids and may be helpful. So most of these HGE dogs, and if I may say, the new terminology is acute hemorrhagic diarrhea syndrome, which is such a terrible mouthful, terrible. These medicine people always want to rename things. But ultimately, you can use that PCV. Oftentimes with an HGE, you'll see this PCV that's really high and a total protein that's inappropriately low. So PCV of 60% with a total solids of 5.2. That total solids is 5.2 because they're losing albumin and globulins into their gut, into their diarrhea. And so it's very tough to use that as an indicator. So more often than not, hopefully you have a recent weight within a past year maybe, but you might have to oftentimes just go off of your physical exam assessment on patients. So things like mucous membrane texture. So are they tacky? Do they have a prolonged skin tint? Excuse me. And things like that for assessing the hydration changes. And then sit here and say, all right, I think this patient's 7% dehydrated. When you first start doing therapy on it, how can I, or where should their weight be whenever I think they're euhydrated based off of that 7%? And that's one thing that I do all the time and I try to target because using other things might be very challenging. It's a very good question and very difficult thing to assess at times. All right, let's get back to the presentation. We're about, how long? Oh, an hour and 10 minutes into this. Thanks for hanging in there, guys. All right, so how are we going to use our fluids? I'm going to go a little bit fast through this. I'm sorry. I just want to get to some of these, working through some of these problems for you guys. That way you guys can get some utility out of it. I welcome you guys staying longer for doing more time with the equations as well, or working through problems. So fluid usage is going to really depend on what condition we're treating. And this is where targeting your therapy is going to be very important. Whether you're dealing with shock or hypovolemia, whether you're dealing with maintenance fluid therapy, I'll say dehydration, diuresis, and then anesthesia. We always need to remember about that. Again, isotonic fluids or isotonic crystalloids, always the fluid of choice in majority of the situations that we're dealing with in veterinary medicine. So talking about cardiovascular collapse, hemodynamic instability, shock, hypovolemia, probably all similar terms. This is not talking about cardiovascular failure, so or cardiogenic shock. That's heart failure. We're not going to deal with that. We're not going to even mention that in here. So what fluid type do we use? How are we going to use it? So we're going to talk about the fluid type and our 3 different fluid types. So hypertonic, isotonic, and hypotonic, and how we can use those in each one of these situations, mostly just as cardiovascular collapse. So we're going to talk about the shock dose of fluids, and that's very important to remember. And I'll have a question here in just a second asking you what the significance is of a shock dose in a patient, and then how are we going to administer that to a patient. So question for you guys, what is the significance of the shock dose numbers in patients? So when I tell you the shock dose for a dog is 90 mils per kg per hour, where do I get that 90 from? That's what I'm asking here. So is it related to their body size, their body surface area, their metabolic rate, blood volume? Which of these do you guys think it's related to? Sorry for coughing. I haven't talked this much in a while. My kids don't let me talk this much. All right, let's see. So body surface area for 13% and blood volume for 87. Good choice for body surface area, not a wrong choice to make. I'm glad that you didn't say metabolic rate. That's when we're dealing more with maintenance fluid rates, body size. Again, good that you didn't say that, because how many fat, morbidly obese animals do we see out here? Ideally, we should not be treating their obesity weight. We should be treating their ideal body weight, but honestly, I don't do that. So blood volume is exactly what that is. So fantastic for those of you that got that one. So when we're talking about shock doses, when we look at hypertonic saline, there's not a shock dose in mils per kg per hour. So how much can we give over an hour time period? What there is a dose that we can give when we bolus fluids to these patients. So when we're using hypertonic saline, for dogs, we're talking about 3 to 7 mils per kg over 15 minutes. Big key part here, 15 minutes. I'd say even 15 to 20 minutes. And so there's a range here. So for a typical dog, I'm probably grabbing about 5 mils per kg, and I'll give that over 15 minutes. You can always give more. You can't really give less. Always remember that. For cats, the dose is typically 2 to 5 mils per kg. So for cats, I'll probably go for like a 3 mil per kg over 15 minutes. Interestingly, these are the same doses that you'll use for using hypertonic saline for intracranial disease in patients. So patients that you think have cerebral edema or head trauma, these are the same doses that you would use for that. So hopefully that's helpful for you. This, again, I talked about how cheap this is, a lot cheaper than using mannitol for those conditions, just as a heads up. All right, isotonic crystalloids. This is the shock dose that we were just talking about. So a mil per kg per hour. So how much volume can we give in 1 hour? For a dog, we're talking 90 mils per kg over 1 hour is what we can give. I've given more in select circumstances and if patient requires it, but often not. This is equivalent to the dog's blood volume, roughly. In cats, we talk about 45 to 60 mils per kg per hour. Choose one of those numbers. It doesn't really make a difference. If 45 is easier math for you to do, then use that. 60 is easier, use that. Again, we're going to do this in aliquot. So we're going to do it in over 15 minutes, so a quarter of the time and a quarter of the dose aliquot. And the reason why is, again, we can give more, we cannot really give less. So the last thing that you want to do is blast a dog with 90 mils per kg over an hour, and then all of a sudden they're in heart failure because, well, they needed some volume, but they didn't need that much. And then you're stuck with a heart failure patient. Cats, same thing. Again, with cats, make sure you warm them up aggressively. The one thing that I will say, many people are scared to use fluids in patients that have a heart murmur. So let's say you have a dog with a heart murmur or a dog that has underlying heart disease. How do you use shock doses in those dogs or cats? You know, you have to be more conservative. So instead of going for a quarter of the shock dose, go for, you know, maybe a tenth of the shock dose. Go for dogs, go for 10 mils per kg over 15 minutes. A cat, go for 5 mils per kg over 15 minutes. You can always give more, you cannot give less. But if you do nothing, they will die of hypotension, hypovolemia. They will die because you did nothing. If they die because you put them in heart failure, giving small amounts of fluid, well, they were probably sitting out there on a stick over a fire anyways. And so they were probably going to die no matter what. Do not be afraid to give fluids as long as you're giving them appropriately. I will always battle that with many doctors I've worked with. Don't be afraid to give them just because they have heart disease. If you do not give them and you've documented that they need them, you're the one that's doing wrong by not giving them. There's always a risk no matter what we do. So just be careful, but do give those and treat appropriately. All right, and then lastly, hypotonic fluids in shock. Never, ever, 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 never, 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 ever do that. So when you bolus hypotonic solutions IV, these can lead to crenation of red blood cells. Not crenation of red blood cells. It leads to pumping of red blood cells, and then they can rupture. And so you can cause acute hemolysis at the site where you're giving these and cause issues there. You can also cause a phlebitis, even if it has dextrose in it. It's always a risk. So just be careful. I would not recommend doing it ever. Hopefully most of you don't have hypotonic crystalloids around. Many people don't. I don't think it's necessary to have in most hospitals if you're doing general practice and specialty medicine probably, but that's about it. All right, so maintenance. Maintenance means a variety of things to people. So we've got different rates of maintenance for dog and different for cat. So dog, 40 to 60 mils per kg per day. From a rough idea, I like simple. 60 mils per kg per day sounds fantastic to me. The less numbers I have to remember, the better. The bigger the dog, the less they need. And this comes back to basal metabolic rate. Remember that an elephant uses less energy than a mouse to maintain their body temperature, just because that basal metabolic rate, and body surface area as well. Cats, we're talking about 45 mils per kg per day maintenance. Just keep it simple. There are all these fancy formulas that you can use. Why bother with all that stuff? Simple, 60 mils per kg per day is sufficient for a dog, 45 for a cat. I love keeping things simple. The easier I can make my job, the better. All right, so dosing hydroxyethyl starches. So these are the VetStarch Volubens products that we have. There are daily doses and there are shock doses that we can use. For daily doses for dogs, 10 to 40 mils per kg per day. And that's for the VetStarch and Voluben. Those are more specific to veterinary medicine than the Hetastarch, Pentastarches, and Tetrastarches. For cats, 5 to 10 mils per kg per day is usually what people may go up to or recommend as a possibility. And then for shock doses, these are pretty similar in mil per kg volumes as saline. Dogs 3 to 5 over, again, 15 minutes. Cats 1 to 3 over 15 minutes. So that's that quarter shock dose time period, but just a different volume because we're dealing with a different product. These are going to have more utility for expanding the intravascular space for smaller volumes than, say, the isotonic crystalloids will. But remember, they're doing that by pulling fluid in. So it's not like you're giving less or you're not expanding the intravascular space. It's not like you're giving less volume total to the intravascular space. You're just providing less to the dog or less to the cat. I hope that makes sense. Sorry. All right. So how are we going to do our dehydration in our animals? Again, very subjective to determine a timeline, or sorry, I did not say this. Subjective to determine how dehydrating the animal is. So always reassess a patient. And the timeline is also subjective. So things to consider. Is it a cat versus a dog? Cats are fluid intolerant. Normal cats can be fluid overloaded on typical rates of fluids. It's stupid. Again, cats is strike at least number 4 by now, maybe 5. Dogs are more tolerant of IV fluid, higher fluid rates. A heart murmur or a gallop rhythm. So these are more likely to indicate that we may have underlying cardiac disease. If you have a heart murmur in a dog and you're going to put them on IV fluids and you're worried about them, get a lateral radiograph and see if they've got any left atrial enlargement. That's a good way to assess underlying cardiac disease. If they don't have left atrial enlargement on that radiograph, you're probably good to give them whatever fluid rate you want. In a cat, radiographs are unfortunately not very useful. That's a tough situation. But dogs that have a heart murmur and cats that have a heart murmur or gallop, do be more cautious with fluids. Again, you can give them less if you can't, or sorry, you can always give them more, but you can't give them less, and you don't want to put them in heart failure for rehydration. Age is also an issue. Remember that older dogs could have underlying cardiac disease, same thing with cats. So in older dogs, I'll go a little bit slower compared to a 2-year-old dog or Labrador. And then most importantly, always reassess your patient. And this is where whenever I talked with students, I always found a way to make it creative for them. So this, I would say, re-asses your patient, because then they remember, oh crap, Dr. Nystrom said I got to re-asses my patient. And then they remember to actually do it. And one important utility here, always include your weight, because again, that's going to give you potentially an objective measurement of where you started and where you're at currently. And then the last thing that many people forget is about ongoing losses. So people will calculate their dehydration, their maintenance that they need, add them together, and then this patient's shitting out its brains, sorry for the language, with massive diarrhea. And then they're just like, why are they still dehydrated? I'm just like, well, because they still need more fluid because they're losing it all through their kidneys. Or chronic kidney disease cats or dogs need higher fluid rates than a non-kidney disease animal, and diabetic animals too. So their maintenance rate is going to be a little bit higher than a healthy patient. All right, talking about diuresis, back to dehydration. The quickest I will rehydrate a patient is probably over 4 hours. The longest depends on the patient, but typically about 24 hours really is what I'll do. Sometimes I'll do longer depending on the patient. If they have a history of definitely being in congestive heart failure before, I will often give it over a longer time period. Better that they're alive than dead because I put them in heart failure again because I was overzealous with rehydration, not with treating shock. All right, so fluid diuresis, big controversies here. What's the best thing to do for our patients? First thing, you gotta make sure you rehydrate them. That's very important. So do we do a rehydration and then maintenance? Or do we do a rehydration and then up to 3 times maintenance? The one big thing to remember is in azotemic patients, just because they're azotemic doesn't mean that you're going to drop their values quicker by giving them more fluids. So that's not necessarily going to be a good thing. So 3 times maintenance may not be any different than just a maintenance, or 2 times maintenance. So just be careful with that. You're more likely to fluid overload patients, especially with kidney disease, because they can be fluid intolerant. I typically will rehydrate them and do a twice maintenance type of fluid rate maintenance again. And then again, most important, fluids are not benign, patient-specific orders. So always trying to target your therapy as best as possible to your given patient. Monitor for your fluid overload. So these are things like clear nasal discharge, which some patients just always have. Sub-Q edema, so you like jiggle their skin like around their sides, and all of a sudden it's just like more flubby than what you would expect. Not quite, I just gave them sub-Q fluids yesterday kind of status, but they just are more jelly-like. Chemosis, so if you flip down their eyelids, what are their conjunctiva? Is it bulging or is it just like normal? And then respiratory distress can be a fluid overload in a normal patient. Let's say a young cat that doesn't have heart disease. You can fluid overload them, not necessarily heart failure, but fluid overload because they don't tolerate that fluid. So all things to look for. These are not the exclusive fluid overload signs, but there are others. These are just more the common ones. All right, hopefully this is the last one. Anesthesia. Oh no, we got anesthesia and sub-Q fluids, so we'll talk about that as well. So current recommendations in anesthesia. This is something put out by AHA back in 2013. So we're long overdue for an update here. But currently in anesthesia, they recommend dogs get about 5 milliliters per kilogram per hour while under anesthesia. So the prior 10 mils per kg per hour, or potentially, I want to say I've seen 20 mils per kg per hour, that's a lot, is not currently recommended. And these are patients that are euhydrated. Remember that. So if they're dehydrated, you need to treat that too. Cats, they're recommending 3 mils per kg per hour is the current recommendation. Some people, after an hour or even half an hour, will cut this rate in half because in theory, maybe they don't need as much volume of fluid going into them. So just something to think about whenever you have your patient under anesthesia, what kind of recommendations you give. Interestingly, for dogs, this 5 mils per kg per hour is about twice maintenance for a dog at 60 mils per kg per day. Twice maintenance. Sorry, I like to use quotations on maintenance. So how do we handle outpatient care? So this might be more up you guys' alley, and so I wanted to throw this in here. I really hope you guys don't have to deal with guinea pigs too often. I'm thankful that I don't have to deal with them anymore, but just a picture of someone giving sub-Q fluids and wearing gloves is very important in many of our species, but subcutaneous fluid therapy is always an option when a patient is hemodynamically stable. So if they are not in shock. With that being said, I have given sub-Q fluids to patients in shock because the owners have no money. And I'm just like, this is a Hail Mary, dude. We're gonna do the best that we can. Hopefully this will work for you. Again, do not give if in shock because it will not treat that shock. It may rehydrate them eventually, but it will not treat their shock. General rule, again, going back to our shock dose of fluids, do not give less than a quarter shock dose of fluids. Criticalists I worked with during my training would yell at me when I would do this. And I was like, but it's a 60 kilogram bloodhound. That's a lot of fluids. And she's like, don't even bother giving it. I'm just like, okay. So in dogs, if you can't give at least 20 mils per kg, don't give it. Because it probably won't do too much. In cats, you can't give at least 10 mils per kg, don't do it. So just something to think about. Do it how you feel most appropriate and comfortable. These are what most people recommend. I have given less than a quarter shock dose in sub-Q fluids since my training, and I feel perfectly fine and I'm okay with doing that. And there's volumes for those. And then always and only use isotonic crystalloids for this. Do not use hypotonic, do not use hypertonic. One last thing, do not give fluids that have dextrose into the sub-Q space. Now this differs for other species, but for cats and dogs, we should not do this. And question regarding that, can anyone tell me why we do not give dextrose sub-Q? All right, let's see what you guys said. Great, so most of you got it right. So it can cause local tissue necrosis and sloughing. Rebound hypoglycemia, I don't know if that's actually a thing. I kind of made that up when I came up with this question. Painful probably is. I'm thankful and very grateful that none of you called me bonkers for saying that. So thank you very much. But sub-Q dextrose in cats and dogs can cause skin sloughing. Interestingly, in wildlife, during my training, when I saw tons of wildlife, you have dextrose all the time and they never had a problem with it. So I don't know where this came from. I never tried to track it down, the source be on it, but just be careful. All right, so let's go through a couple case examples. I got 2 case examples here at the beginning, and then I'll go through my thank you for coming and enjoyed it. And then there's one more case example at the end if you guys want to hang around and talk about that. So I'm going to talk, oh yeah, so sorry, this is math. Actually, before we get to doing this, let me take a moment to answer one question. So we got one question. Do you use a pro-BNP as a determination of fluid rate / amounts in cats? So can you use our assessment with the Bayes natriuretic peptide assessment to determine fluid rates in cats? And that is a great question. I don't know the right answer to that. Really, what I would say is that pro-BNPs are typically used to differentiate respiratory distress due to a primary pleural effusion versus a secondary to congestive heart failure, or potentially even evaluate a patient that may be more likely to have underlying cardiac disease. So you hear a heart murmur, you run a pro-BNP, is it elevated or not? What I would say is if everything points to the possibility of an animal having heart disease, maybe be a little bit more careful. So this would be the heart murmur, the gallop rhythm, which isn't always the case in an elevated pro-BNP. Maybe that's more likely to have heart disease. Maybe we should be more careful in that patient. I think would probably be the best way to answer that question. I have not used a pro-BNP at the time of presentation to sit here and say, all right, I'm good. I can give this cat buckets of fluids and it should be fine. And I don't know if there's been a study done looking at that, not one that I'm at least aware of. Good question, though. All right, so math. Oh, I love math. I'm trying to teach my kids that use math for everything. All of this math is done in kilograms. Just as a heads up to you guys, I do write pounds in there once or twice, just that way it's also given. But we'll go ahead and do some math problems here. All right, first we're going to talk about Fred, a little bubblehead Fred here. So Fred's a 3-year-old male castrated Chihuahua, 5 kilograms, 11 pounds, but 5 kilograms. That is presenting for evaluation after 2 days of vomiting and anorexia. All the cases, most all these cases that I'm going to evaluate or talk about here are cases that have clinical signs or clinical history, as opposed to, Joe Schmo brought in Fluffy, who is doing fine for vaccines, and I assess them to be dehydrated. So I'm trying to target more patients with abnormal or disease going on, just to let you guys know. All right, so 2 days of vomiting and anorexia. On physical exam, Fred's got tacky mucous membranes. He's got a normal skin turgor and a normal heart rate. Everything else on physical is boring on Fred here. He probably has some bad teeth because he's already only 3 and he's a Chihuahua, but that's about it. All right, so where is, based off of this, oh, sorry, my bad, Matt. I'm gonna move this aside real fast. Based off of tacky mucous membranes, normal skin turgor, and normal heart rate, where is Fred's fluid deficit? So what space does he have a deficit in? Is there no deficit, an intravascular deficit, intracellular, or is there an interstitial deficit? Let's see how much you guys retain. All right, let's see what you guys got. All right, so 10% of you said no deficit, about a quarter of you said intravascular, and 2/3 of you said interstitial. This would be normally the part where I sit here and say, hey, tell me about why you chose each one of these. And make you really squeamish, start to sweat beads as everybody's looking at you. But unfortunately, I can't do that. So lucky for each one of those answers. So we'll go through it. So for Fred, where is his deficit? So when we talk about our interstitial space, our intravascular space, when we talk about interstitial, we're doing things like mucous membrane texture, skin turgor, sunken eyes, doughy abdomen, a little bit of cementation change maybe. When we're talking about our intravascular, we're looking at mucous membrane color, capillary refill time. Oh, one thing I didn't talk about, I apologize, in that slide is pulses and pulse pressure. Let's see, things like cold extremities, tachypnea for cats because they're silly, bradycardia for cats, tachycardia for dogs, those kinds of things, temperature for cats. All right, so we look at this, we got tacky mucous membranes with a normal skin turgor. So I would actually, sorry again, Matt, I would actually classify this dog, Fred here, as having an interstitial fluid deficit just because it's tacky mucous membranes. He's got a normal heart rate, which makes it less likely that he's got an intravascular deficit. And that's the only thing I gave you to assess the intravascular space is the heart rate. So for me, he's got an interstitial deficit. So next question, what is his interstitial deficit? See what you guys think. All right, 3% for a quarter of you, 5% for most of you, 7% for 7% of you, and none of you thought 10%, so that's good. So at the beginning, and you guys might have missed this, I don't know how many people guessed the 3%, I can't see absolute numbers, but I talked about fluid deficit in the interstitial space. You cannot detect anything less than 5%. So based off of that, there's no way that he is anything less than 5% for Fred here, because he does have tacky mucous membranes, which fits with a dehydration or a deficit in interstitial space. So he's got to be at least 5%. So for him, I think he would kind of qualify for this 5 to 7% dehydration. Since he has a normal skin turgor, he's a young dog, no mentation changes at all. He's maybe more likely that 5% category would be where I would put him. Again, this is subjective assessment of our patient and giving him a given number. So some people might say 5%, some people might say 6%. I would say nothing, it's got to be at least 5%, again, because he's got tachymucous membranes. All right, so let's see what's next. Oh, what is Fred's maintenance rate? So back to maintenance fluids, I am going to be using 60 mils per kg per day for his maintenance rate, because for me, 60 mils per kg per day is very easy math on a mil per hour basis. You take their weight, you multiply by 60, you divide by 24 hours, which is the same thing as multiplying their weight by in kilograms by 2.5, and that will get you the mils per hour. All right, so 60 mils per kg per day times his simple little 5 kilogram weight, we get 300 mils per day. Divide that by 24 hours in a day, and we get 12.5 mils per hour. If you guys do the math, 2.5 times 5 is 12.5 also. Again, if you don't have a fluid pump that goes 12.5 mils an hour, go 12, go 13. You know, there's variations in what a patient really needs. So no, neither one of those is wrong. All right, so 12.5. So now we talk about dehydration or a fluid deficit in the interstitial space. So this is the equation that you can use. Their body weight in kilograms, again, kilograms, everything in kilograms, times their percent dehydration. So 5% becomes 0.05 when we make it into a number from percentage. And then times 1,000. And the reason why we use 1,000 is we're converting kilograms. 1 kilogram is equivalent to 1,000 milliliters. And we want our fluid deficit to be in milliliters. That's why we multiply by 1,000. The answer that you get from kilograms times their dehydration will be liters of deficit. So multiply by 1,000 and you get your milliliters. So Fred's fluid deficit, we know he's 5 kilograms. I'm assessing him to be 5% dehydrated, so 0.05, and then times our 1,000 milliliters to get from liters to milliliters. The number I got for that is 250 mils. And then how quickly do we rehydrate Fred? 3-year-old dog, young, no health issues, no murmur, no nothing. The sooner we get him rehydrated, the sooner he feels better. So this would be a dog that I would say, why don't we do it over somewhere between 4 to 6 hours? Probably, I typically tend to go more closer to 6 for easy math sake. Simple, 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 easy math. I chose, oh, here we talked about, I just said this all, sorry. I chose 5 hours because 250 divided by 5 is something I can do in my head. Make it as easy as you can on yourself, but 50 mils an hour. Remember, we went back, maintenance rate for this dog is 12.5 mils an hour. Now we're saying 50 mils an hour. Look at how many maintenance is that? 4, 12.5, 20, yeah, 4 times maintenance for his rehydration rate. That's just the rehydration. And then we got to add maintenance on top of that. So 5 times maintenance to rehydrate him over 5 hours. Holy smokes, that's so much volume, right? But he will feel better. He should be able to tolerate it too. So what's his total fluid rate? This is where we do our maintenance rate plus our rehydration plus, don't forget, our ongoing losses. Fred has no ongoing losses because he doesn't have any diarrhea. Hopefully we've controlled his vomiting with a medication, whatever you choose, whether that's ondansetron or meropitant, your choice. Metoclopramide if you use that. And let's also say that he doesn't have an obstructive foreign body, so it's okay to do this. So 12.5 mils an hour for his maintenance, 50 mils an hour for his rehydration over 5 hours. Important to always remember that. And 0 for ongoing losses. So 62.5 mils an hour for 5 hours. Then, oh, sorry, circles. All right, and then what are we going to do? We're going to re-asses our patient, right? Re-asses, re-asses. Always remember to re-asses your patient, which most of us are going to do anyways. But just make sure you're re-assing your, reassessing your patient. Sorry, in the appropriate ways to know that you've done what you wanted to do before potentially sending them home or something else, whatever your next plan is for them. All right, so just checking in. Anybody have any questions? Or I guess, poll. Who is more confused than before we started? I feel like I'm in a chair, or that old vestibular dog. I got it. You ready for me to really push you? Eventually I'll get there. I'm slow at math. Or who really hates math, really? All right, let's see. All right, so about half of you are ready. Of course, someone had to do what is math again. And the others of you will get there eventually. Again, I'm going to send out the slides to you guys with the certificate of the CE certificate. So you'll have access to all these. So all these math problems will be on there as well. Hopefully that will help with being able to go through it. My email is also on there. I do welcome you guys giving me a call either at work, emailing me. I'm not always the quickest at responding to email, but I'd be happy to go through things with you guys. I do want to take a moment. We got two questions. Actually, one's a question, one's a clarification. So someone said they've heard that you shouldn't give fluids spiked with potassium chloride, so KCl, sub-Q in patients because they can also have reactions. Any thoughts? And what about calcium gluconate added to fluids? Great question. I have heard the same thing about KCl added to fluids. What I will say about that is I have had tons, buckets and buckets and buckets of patients that are on fluids that have KCl in them, and then their catheter blows and it goes all sub-Q. They do perfectly fine. Most of our fluids, those balanced electrolyte solutions, so Plasma-Lyte A, Normasol R, lactated Ringos, all have potassium and they all have chloride in them. What I would not say don't give a fluid that is just KCl. Don't give an injection of KCl sub-Q to correct your patient's potassium. That would be a bad idea. But maybe light levels of KCl in fluids would probably not be a terrible idea. Maybe you can get away with it. It probably would be all right. Up to, let's say, 20 or 30 milliequivalents per liter of KCl might be reasonable. Calcium gluconate. That is a great question. I do not know if you can give calcium gluconate sub-Q. My guess would be no. I know you can't give it during CPR via intratracheal through an endotracheal tube, but that's not very helpful for this question. So I don't know. I would probably say that it probably would be a bad idea to give it. So I would avoid it, giving it. I would reach for something like oral calcium if you can do that. Good questions. Oh, someone snuck in another question here. When do you chart or change from rehydration fluid to maintenance fluid? Is it okay to just continue LRS? Absolutely, just continue LRS. That's what I do 99.9% of the time. I continue a patient after they've been rehydrated on an isotonic solution. I will often continue them on the isotonic solution. I do not hang 2 bags of fluids. Now, that chronic kidney disease cat, I often will switch over to 0.45% saline because one, it's a cat, and they are cats that don't tolerate sodium, and 2, it's got kidney disease that also is less tolerant of sodium loads. Oh, one last answer or question here. Do you use turbo starch? What a great question. I have never used turbo starch. So what turbo starch is a combination of hypertonic saline and a hydroxyethyl starch product. Usually people make it on their own. They do a mixture of some mils to some mils. I don't actually know the mixture there that they do, but it can be great for resuscitating patients that come in hypovolemic or hypotensive. Great for a hit by car patient that probably is euhydrated, so normal interstitial space, but hypovolemic because they've had some blood loss. My resident mate that took over critical care after me started using it a whole lot more after I had left. So definitely a product to consider using if you have both available. I've seen good utility or heard good utility. Last question, and then I'll move on to the next question. Someone asked to explain the 2.5 times 5 kilograms to get an IV fluid rate. Will it always be 2.5 times their weight? So when we're dealing with maintenance in dogs, if you want to use 60 milliequivalent or 60 milliliters per kilogram per day, I can annotate. Let me see if I can write text. Let's see. So if we do 60 mils per kg per day, and we multiply times their weight. So let's say their weight is 5, we just did 5 kilograms, 10 kilograms. Their maintenance at 10 kilograms will be 600 mils per day. So 60 times 10. And then we divide by 24. Let me pull up my calculator here real fast. Sorry. 600 divided by 24 is equal to 25 mils per hour is what our rate would be when we divide 600 by 24. So, but that's the same thing as taking 10 kilograms and multiplying by 2.5 to get your mils per hour. It's just a shortcut that I realized, something that made it easy for me to do when I'm using my maintenance rate of 60 mils per kg per day. It might be overcomplicating things to remember all those numbers and adding 2.5 on top of it, but you can use that. Someone said, or close to body weight in pounds. Hey, yep, absolutely. So mil per hour and body weight in pounds. So 20 or 10 kgs is 22 pounds. That's almost 1 mil per pound per hour. Absolutely, great point there. I really appreciate someone pointing that out to me. Never thought of it that way. Very simple way to do it. All right, great question. So we're gonna move on. Next problem, let me get some of this stuff off of here. I'll leave the text there because I don't care. All right, back to, oh gosh, text, go away. I don't want you to, oh no. All right, I don't know how to get rid of that text, so you guys will have to ignore that maybe. All right, so Fred, any questions? I think we answered all the questions there in the previous slides. So let's move on to, let's see, we got about 7 minutes to get through this next problem. So I'm gonna go a little bit quicker for you guys. This is a little bit more complicated too, so hopefully you guys can stay up with me. So Fiona, a middle-aged 6-year-old female spayed yellow lab, 30 kilograms for you guys, pounds, 66 pounds, 30 kilograms, 4-day history of vomiting and diarrhea. So diarrhea, remember, potential ongoing losses here. She comes in obtunded, white and tacky mucous membrane. So with a refill time that's unable to assess. So I gave you texture, color, and refill time. Weak pulses, tachycardic, so heart rate of 180 for a yellow lab is probably inappropriate, especially one that's obtunded and not excited. And she's got watery diarrhea on rectal. So Fiona's status question here, is she stable? Does she have, or the other way to phrase this is she in a life-threatening state right now? No, that's the wrong way. Is she stable? So if we do nothing, is she gonna live? Nope, still the backwards way. Sorry, is she stable? I'm gonna give up. Let's see if I can get rid of this text. All right, yes, 100% of you say no, she's not stable. I love it. Thank you very much, guys. You guys rock. Next question. Where is her fluid deficit space? There we go. So is there no deficit, an intravascular deficit, interstitial, or both? Oh, here we go. Here, all drawings. Ah, got the text off of there. All right, so 87% of you hit it right on the pen. She has a deficit in both her intravascular and her interstitial space. Very good job, guys. So let's look at her real fast in her exam findings. So we're gonna talk about the most life-threatening issues here first. So her intravascular fluid space, white tacky mucous membranes. Let's assume that she is not anemic. Capillary refill time, unable to assess. Sorry, there's not a circle on the other side. Too many circles here. She's got weak pulses, something that I forgot to add in the front of my presentation. She's tachycardic. And the other thing that I could have included is this obtunded over here as an assessment of vascular space, but I did not include that just because that can go with both of them. And what about her interstitial space? She has these tacky mucous membranes which supports a dehydration. So good job, guys. All right, so we're gonna talk about shock dose and giving shock doses of fluids. Remember, 90 mils per kg per hour for a dog. That is the total shock dose over 1 hour. We're gonna give it in aliquots, so 1/4 little aliquots. All right, so we need to treat her shock first. Most important thing, life-threatening disease. So 1 mil, or shock dose is how many mils over 1 hour. We talked about 90 mils per kg per hour. For her, 30 kilograms, 2,700 mils over 1 hour. If you wanted to give it in the whole volume, don't do that. We're gonna give it over 1/4 of the time, 1/4 of the volume. So you can go back and do 30 times the 90 divided by 4, and that'll get you your shock dose. Or you can just choose 20 or 25 mils per kg and divide by 4, and that'll get you close to the same volume too. So we're gonna give her about 700 mils over 15 minutes, not over 3 minutes, not over 30 minutes, not over an hour, because that's not gonna do anything. I'm gonna give it over 15 minutes. So important, 15 minutes, 15 minutes, 15 minutes. All right. Then what are we gonna do with our patient? This is where I really listen and I go, I can hear you guys say it. Re-asses our patient, right? Always re-asses our patient. All right, so we re-asses her. Now she's quiet and responsive. She's pink. She still has tachy mucous membranes. Her refill time is about or is less than 2 seconds, so great job there. She's got good pulses and her heart rate's now 100. So looks like we did a great job. Are we done? We can just walk away. See you later, Fiona. That's where we can get into trouble. So, and I did not talk about this yet, but whenever you give an isotonic crystalloid, the hypertonics are a little bit different here, but an isotonic crystalloid lasts in the intravascular space for about 30 to 45 minutes. So similar to if you were to give fentanyl, if anyone remembers giving fentanyl or lidocaine as a bolus, they only last in the body for a short time period. So what we have to do after giving a bolus is then support that bolus with ongoing fluids. So a hypotensive shocky patient should have a bolus of fluids and then an infusion of fluids, even if it's just maintenance, because we think they're dehydrated, or a rehydration rate over at least probably a few hours to make sure that they maintain that stability. If you don't support them at all, they will become hypotensive again in about 30 minutes to 45 minutes. All right, so we stabilize them. Now what do we do for Fiona? Again, support her fluid bolus by maintaining her and giving her some intravascular volume, even if it's a maintenance rate of fluids, and then start your rehydration on top of that. So what is Fiona's maintenance rate of fluids? 60 mils per kg per day, 30 kilograms, 1,800 mils in a day, 75 mils an hour. I'll let you guys go through all that. Now we got to talk about her fluid deficit. So how dehydrated is she? She's got the tachy mucous membranes, but no prolonged skin tint. So maybe we'll just go with 5% for her. Done all this math. So her fluid deficit is 1,500 mils based on her weight. And how quickly would we give it over? Let's see. So she's younger. She didn't have a murmur on presentation. So maybe we can do it a little bit quicker for her. Let's see what I chose. 6 hours. Probably a great rate. Because that's 250 mils an hour. 250 mils an hour. That's a lot. This will likely make her urinate more, and she might not get as hydrated the quicker we rehydrate her, because we're also going to be pushing a lot of fluid into her glomerulus and increasing GFR. So we might lose some of this fluid at this high of a rate, but it's okay. That's why we always re-assess our patient. So what's her total fluid rate? So we've got our maintenance that we calculated of 75 mils an hour, our rehydration of 25 mils an hour, and let's just say she's losing about 15 mils an hour in her diarrhea. This is a subjective, put a number out there. Don't do something like 100 mils an hour. That's just ridiculous. But come up with something. 2 mils, 5 mils for smaller patients, 15 for a dog like this. You can always reassess it later on and add more if you need to. So 340 mils an hour for 6 hours. So you're going to go through 2 bags of fluids in 6 hours for this dog. At least 2 bags of fluids, right? Yeah, 2 bags, at least 2 bags of fluids in this patient. We already talked about how she's 1,500 mil deficit here. So there's 1.5 bags of fluids, and then her maintenance on top of that. All right, so that's a big rate of fluids, but I've done it all the time. I've gone up to 400 and some mils an hour. I've given a dog 23 liters of fluids in 24 hours to get it rehydrated because of ongoing losses and persistent dehydration. It was ridiculous. But remember, after we get to that 6 hour mark, we're gonna re-assess Fiona before we decide what's the next thing for her. All right, so quick summary here. And then we'll have some question time. And then if anyone wants to stay on and do one more problem, I'm happy to do that. So we have dehydration and hypovolemia. The area of deficit for dehydration is the interstitial compartment or interstitial space. And this is typically not life-threatening. Very important. Typically not life-threatening, interstitial dehydration. Hypovolemia is the intravascular compartment or intravascular space, and it is typically life-threatening. Hypovolemia, intravascular, life-threatening. Simple. You guys got it based on your responses so far, so I've been very pleased with that. All right. For our patients, remember, isotonic crystalloids are the fluid choice in veterinary medicine, actually in human medicine too. Remember to tailor your treatments to your patients along with their concurrent diseases. So don't just blast them because you can, blast them because you know you can based on your patient assessment, or go more slow and be more timid about it because you feel like you should be more cautious. Fluids are not benign. Monitor for the side effects. These are a prescription for your patient. Sub-Q fluids a prescription. IV fluids a prescription. Always remember that, a prescription for your patient. Take it seriously. This is your license. And then I've got at least a few questions. I'm happy to take any other questions on top of that. Do not leave yet until I'm done answering the questions. I just wanted to tell you guys about the next session that we're going to do for Vets Pets. But I'm going to go ahead and answer the questions that we already have in here. All right, so someone said they would give 1,000 milliliters to Fiona at a fasture. That would be absolutely fine. Some people will like to give patients, if they're dehydrated, I've worked in lots of places that will give animals a bolus of fluids. So instead of giving that shock dose or that quarter shock dose over 15 minutes, they'll give it over like in half an hour to an hour. That way, maybe they're getting a quicker jump on the rehydration. What I will say is that you're going to encourage lots of increase in their GFR. And so if you give 1,000 mils over half an hour, you might lose 200 or 300 of that to increasing the GFR. And so again, just important that you just reassess your patient along the way. So certainly a good point. If you don't have a fluid pump, fast drip is absolutely fine. And would you ever give IV and sub-Q fluids at the same time or close together? Yes, I have done it. So I remember exclusively a patient that came in stark white in the ER, an intact female, and I was convinced that she had blood coming from her backside. I was convinced she was a pyometra and she was going to die, and she was anemic because of that. And this was infancy in my residency. And that dog had a PCV of 82%. Clearly not anemic, but holy smokes, 82%, one of my highest that I've seen. And so the owner couldn't afford hospitalization. So I gave that dog a bolus of isotonic crystalloid. I gave it a bolus of vet starch because I think its total solids were 6 with an 82%. It ended up having acute hemorrhagic diarrhea syndrome, or HDE. So IV crystalloid fluid bolus, vet starch bolus IV, and sub-Q fluids, and said, this is the best I can do. Guy called me 2 weeks later and said, she's doing great, man. You saved her life. So awesome. So grateful. That would never happen in the hospital. If I put that dog on IV fluids, it'd become peripherally edematous, blow up like crazy. I'd be $4,000 in the hole and the dog would still look like crap. So I think that's less common that they do that well, but I will always remember that case. So I certainly do give IV fluids and sub-Q fluids at the same time. But it's mostly in instances where I don't have time with the patient because of finances, or owners just elect that they don't want to hospitalize a patient. Good question. Any other questions out there? All right, well, if you think of them, go ahead and throw them up there. Last thing for you guys, in another month, so May 25th, we're going to have another CE event hosted by Vets Pets. It's going to be Dr. Janine Moga, who is a licensed clinical social worker for veterinary medicine. I'm not sure what the MSW stands for, I'm sorry. Probably Masters in Social Work. But she's going to talk about crisis and conflict management for veterinary teams. So this is going to be a lot of discussion about how you can not necessarily manipulate clients, but manipulate your communication with clients to better manage them as best as possible, and your teams around you as well. So should be a pretty good CE. I've not attended anything from Dr. Moga, but I've heard great things about her. So please look out for the invitation for that, and please feel free to join us for that as well, because that's going to be good. We do these CE lectures. We're trying to do them once a month. I think the third or fourth Sunday or Thursday of the month. So always look out for it. We've got a variety of talks. We just got done doing a surgery one, me, and then Janine's going to give this next talk. So, all right, let's see. It looks like we still got 39 of you. For those that need to go do your kid stuff or do your other stuff, these next slides will be in the PowerPoint or in the PDF sent to you guys. So feel free to do that. If you have any questions or answers, I will answer those as we go along here as they pop up. But we'll work through one more case. She's a little bit more of a complicated case because she's a cat. That cat. Ah! But this is Penelope. She's a 17-year-old female spayed domestic short hair, so older. First thing that you got to make sure you pay attention to, She weighs about 3 kgs or 6.6 pounds, for those that like the pounds. And she has a history of chronic kidney disease. Again, so we talked about she's old, she's got chronic kidney disease, things to remember, and she's been anorexic for 3 days. When she comes into you, she's obtunded, she's got tachy and white mucous membranes. Let's assume that she is not anemic, even though she has chronic kidney disease. Assume that she's not anemic for these cases. She's got a prolonged skin turgor. She's bradycardic at 130, abnormal for a cat, definitely. Difficult to palpate from oral pulses. One caveat here being cats, if you can't palpate the pulses, it doesn't always mean anything. If they have pale or white mucous membranes, doesn't always mean anything. Again, more strikes against the cat. Sorry, kitty cat. Sorry, Penelope. And then she's hypothermic. So, question for you guys is, where is her fluid deficit space? Or sorry, where's her fluid deficit, not space? What space is it deficit in? I'm getting tired. Anybody else getting tired? Thank you guys for hanging around. I really appreciate it. And thank you for attending. All right, let's see what you guys put. Where does she have a deficit? Intravascular deficit, so 11%. And then 89% said intravascular and interstitial. So great. So we'll go through her real fast. Things that make me think that she's got an intravascular deficit. Her obtunded, and this is the thing that I did not comment on for, I believe, Fiona, but obtunded can be either dehydrated or intravascular or hypovolemia, but we'll go with hypovolemia on this one. Bradycardia, we talked about the triad of shock in cats. Hypothermia, there's the second one. We didn't talk about a blood pressure here, but I can almost guarantee you her blood pressure would be low if we assessed it. So bradycardia, hypothermia. Back to the white mucous membranes, it's difficult to palpate from oral pulses. She's a cat. Cat. May all be normal for her. And then for her interstitial deficit, she's got tachy mucous membranes and this prolonged skin tint. Old and chronic kidney disease, 2 strikes against assessing their skin tint. Let's assume, though, for her that this prolonged skin tint is a real prolonged skin tint and not due to her old age or her age and her chronic kidney disease. All right, so shock dose in cats. We need to treat that first because that's the most important thing. That's the life-threatening thing. So what are we going to give her? We're going to give her 45 mils per kg per hour is the shock dose that I've chosen for cats. So remember, it was 45 to 60 mils per kg per hour for shock dose for cats, 90 mils per kg per hour for dogs. We're going to give that 135 mils. That's the total volume that she can get over an hour. But we're going to give an aliquot. We can always give more. We can't give less. She doesn't have a heart murmur, so we're not worried about that. 50% of cats that have a heart murmur have underlying cardiac disease. There's probably also 50% that don't have a heart murmur that have cardiac disease. So just be careful. You can always give more later on, so you can start with a lesser volume. 135 mils is a lot to give over an hour. 34 mils is much more appropriate. Many times in shock cats, I will often just grab 50 or 60 mils and pull it up out of a warm bag if you have it and give that IV. Is often what I would do. So 34 mils over 15 minutes. And then we're going to reassess her. Oh, shoot, I guess. But what if she has a heart murmur? I don't remember saying that or seeing that. So what happens if she has a heart murmur? How do we prevent from pushing her into heart failure? What will Penelope die from first? That's the most important question for you right now. What will she die from first? For hypotension, if I leave it untreated and don't do my job as a doctor? Or from her heart failure, if I treat her hypotension and then she goes into heart failure? Which one's going to kill her first? All right, good job, guys. I love it. I don't remember putting that she had a heart murmur. I must have missed that. Hopefully I actually put it. Sorry about that, but you're absolutely right. She will be more likely to die of hypotension if you go from heart failure if you treat appropriately. And again, you're walking a thin line here, so it's very tough to sit here and determine, how do I appropriately treat a patient that could have heart failure? You can always give more, you cannot give less. But doing nothing treats nothing, and that patient will eventually die. So I strongly encourage you to treat the hypotension, treat the hypovolemia, treat the shock. If if you believe that it's non-cardiogenic shock, because that's going to be this thing that saves the animal. It's like saying, you know, actually, I don't have an example. I'm not going to go through that. It's going to be silly. All right. So sorry, guys. I digress. So Penelope will die from shock. Remember the triad of shock in cats: hypothermia, bradycardia, hypotension. Very likely that she would be hypotensive, given that she was bradycardic and hypothermic on presentation. This would be one that I might not even try to get a blood pressure on. And she can only die from heart failure if she has underlying heart disease and does not tolerate life-saving treatment. So if you give her life-saving treatment and she does not tolerate it, well, she was in a terrible place. She was probably going to die no matter what. You've done nothing that caused her to die. You've only done stuff to try to save her. And she did not want to be saved. That's a terrible way of thinking about it, but something just to kind of chat with clients that might make you feel better or make them feel better afterwards. All right, again, only 50% of cats with heart murmur have structural heart disease on echocardiogram. So if they have a heart murmur, that doesn't always mean heart disease, but just be careful. All right, so let's say after we give a 1 warm fluid bolus, she's still obtunded, she still has all the same findings pretty much. Her temperature came up 0.2 degrees. So now what are we going to do? Aggressively warm Penelope. This is the cat. This is a patient that in felines, if you continue to bolus them, once they get to be normothermic, they will become fluid overloaded, even in a young cat that has no heart disease. So aggressively warm them until their temperature is up above 98 degrees. And then they're hopefully they're what I call a hypothermia-induced vasoplegia will resolve. I don't know if this is really true terminology here. This is just something that I came up with in my head a while ago, and I don't think I've ever looked it up, so don't hold me to that. Sorry. All right, so what is Penelope's dehydration status? Remember, she had tachymucous membranes, prolonged skin turgor, she had an abnormal mentation. I advanced to the next slide too quickly. I'm sorry for that, but I can't go back at this one. How many people? We still got 29 people still hanging in there. Oh, it's just after 9 o'clock. I feel like I've done pretty good here. Thanks, guys. This makes me very happy, warms my heart. I wish I could see everybody sweating, getting nervous as I ask this question. Oh, so 7% for half of you, another half of you said about 10%. So I think I probably for her, that's tough. I would definitely think close to 7%, assuming that this increased skin turgor is real and not due to her being an old chronic kidney disease cat. I have a hard time putting her above 7%. Maybe 7 to 8%. Again, it's all subjective. So my answer is not the right answer. Your answer is not the wrong answer, or vice versa. The most important thing is to remember, you can always give more, you can't always give less. So if you say, you know what, maybe there's 7, 8, I'm not quite certain, let me start with a little bit less of a deficit and rehydrate that, and then I'll re-assess my patient, and maybe I'll find out if I got to where I wanted to be, if she's where I want her to be. Might be the best way to assess it. So, but none of those answers are wrong by any means. So it looks like I placed her at 5 to 7%. I'd probably say 7% would be what I would do for her. All right. So Penelope's temperature and her bradycardia normalized when we use patient warming devices, and she's now responsive. So what is our maintenance fluid rate? If we use 45 mils per kg per day, she will be about 5.6 mils an hour. So not a whole lot here. But the one thing we got to remember for her, hopefully this is, oh man, I don't have it on this slide. Next slide. We'll come back to that. So her maintenance rate of 5.6 mils an hour. Not a very much compared to like say Fiona, who was 75 mils an hour. All right, so what's Penelope's deficit? I use 7% here. So her weight in kilograms times 0.07 times 1,000. So 200 10 mil deficit. How quickly do I want to do this? She is an older cat, which also has a heart murmur. Sorry. So consider doing a little bit slower, maybe 18 to 24 hours, if that is a possibility for you. If it's not, try to rehydrate her while you have her in the hospital. let's say do 6 hours for part of her hydration, and then maybe give the rest sub-Q. That might be a reasonable option for her. So divide it into, give a quarter every 6 hours, and then give the rest of your 18-hour bunch. You do 24 hours sub-Q fluids. That would be perfectly fine to consider doing for her. Or just do half of her rehydration and sub-Q fluids, see her back the next day. So that way you don't potentially push her too hard, too fast. All right, so I chose rehydration over 24 hours is 210 divided by 24 is 8.8 mils an hour. Fancy circle dance. All right, so what's our total fluid rate? So we're gonna go a maintenance rate, a rehydration rate, and we can't forget our ongoing losses. So maintenance for her was 5.6 mils an hour, 45 mils per kg per day for her. Rehydration at 7% over 24 hours is 8.8 mils an hour. And then she has no ongoing losses. So this comes out to 14.4 mils an hour for 24 hours. And then afterwards, we're going to reassess her. The one thing that, let me see if it's on the next slide. Nope. One thing I did not include in her was she has chronic kidney disease. So her maintenance rate of fluids is probably going to be higher than a normal 2-year-old cat. So maintenance for chronic kidney disease, I, for some reason in my head, have selected 1.5 times their maintenance. So instead of 60 mils per kg per day, I'll use 90 mils per kg per day for a dog. Instead of 45 for a cat, I'll probably use like 60 mils per kg per day for a cat. So that's just something I've come up with in my head. I don't know if those are actually right. I don't know if that makes any sense. Again, just something I made up in my head. So those can either be included in ongoing losses, or it can be included as an increased maintenance rate because her fluid outgoing rate is higher than what it normally would be because of her chronic kidney disease. I think that's it. I'd love any questions if you guys have any. Thank you guys all for staying on board here for an extra 10 minutes. I really appreciate it. That makes me very happy. I hope that this has been helpful to you guys. Again, you will get the slides. My email is on there. Feel free to email me if you need help along the way with anything. You need help with a consult not having to do with fluids on a patient, or if you need more clarification of some math stuff, I'm happy to help in any way possible that I can. I love helping as much as I can. So thank you guys very much. If you have any questions, I'll stay on here for a couple more minutes and answer those to the best of my ability. Otherwise, I hope to see you guys in the future. Oh, question popped up. Oh, thank you. You're very welcome. I hope that it's been a good learning opportunity for you. Oh, you're welcome, Beth.